Just a little bit of saline here just to clear everything out. It's good to see a good amount of heme, which is normal. Okay. And the last drill here. Ready? Okay, good. That's the last drill that we'll be using for this particular implant. We're just going to irrigate out here. A little bit of saline. Alan has done very well. And Lori's going to take the bone from the bone trap. Okay, now. Okay, just a little bit of saline rinse. And this one is 3.3 implants going to be placed in this position. You'll feel a little bit of compression, that should be it, okay? Mm-hmm. Raise a flap on this side. Okay. This is a bigger bone block. Yeah, this on this side a little bit of a problem with on the buckle. There's too much compression. Let's see how this one is. This should be no problem. Okay, chin down a little bit. Good. That's good. Okay. I'm going to rotate it so the flat part of the hex for the abutment, we line up the internal part of the hex. What you're seeing there is right here, the flat part of the hex is lined up. So that implant solid, it's down, exactly what we want. Okay. Good. Roger. I'm going to take off the carrier of the implant. Chin down just a little bit. Okay, that looks good. We're going to go ahead and just try to get optimal depth of the implant.
I'm
just trying to see one thing. Here's the angulation. The right side is perfect. The left side will need a flap. Okay, just a little deeper. Dr. Garber will need a little bit of depth to emerge out from this implant. So we're going to go ahead and give him that room. Okay. There's the depth there. There's 3 on the palate and 2 on the buckle.
You gotta give me connected to shoulder.
Rather good angle. What we're talking about right now, Dr. Garber and I, is the angulation of the abutment, and it appears that the angulation's coming out just lingual to the incisal edge of the adjacent teeth, probably allowing him to go ahead with a standard straight abutment. He's about 2 millimeters deep on the buckle, which will make it a fairly straightforward impression and restoration once the implant is healed. Okay. This is the healing abutment going into place. Chin down a little bit. Good. And this is a 3 millimeter healing abutment, straight, no flare to it. And there's the implant in place. You can see that Dr. Garber will have a little bit of depth, just enough to be able to restore the case. Not a whole lot, a lot of attached gingiva on the buckle. You can see all of this is attached. And because of the lip line issues in this case, I believe that this would probably be a very straightforward restoration. On the left side, a little bit of difficulty with the facial plate of bone. Perfect. Left side, we run into a little bit of problem with the location, not the amount of bone, but the location of the bone is too far to the lingual. So I have to put the implant in, but I'm going to have to do bone graft, and I couldn't sneak it in. That's one of the things, in a lot of ways, this will be a very educational video, because if you remember in the video, we were trying to see if we could sneak it in to the lingual by avoiding the concavity. On the right side, we were able to do that, but on the left side, we weren't. And that happens sometimes, and you have to be prepared and go to courses and learn when that's gone that you need to be able to do bone grafting procedures, whether they be minor or sophisticated bone grafting, depends on the severity of the defect. In this case, it's somewhat of a mild to moderate defect. We knew it might happen. I just felt more comfortable on this side. On the left side, going ahead with a more standard procedure, making sure we graft it, whereas on the right side, we were able to maintain adequate bone volume on the labial aspect of the implant. I didn't feel we needed to do that. So on the right side, he got a very simplified procedure, no incision, incisionless, one stage, a very long implant, 16 millimeters, 3.5 diameter. Zimmer tapered screw vent implant was placed with no complication. On the left side, I wouldn't say it's a complication because we were aware of it before the procedure due to the CAT scan. And now that we were about to place the implant, we understood that there was a limitation there that we could not look past, because this needs to be addressed at the time of surgery. So we're going to slightly modify the procedure on the left side. We were hoping they would both go the same, but on the left side is going to need a little bit more bone grafting than the right side did.
And this is not actually an uncommon situation, because if you're looking at the view, you'll see because there was never a tooth present in this situation, the alveolus is not fully developed on the buccal. And you can see it rather nicely in that view. The buccal, instead of a convexity normal to a root, is actually a concavity. And you're looking directly at it now.
Okay.
So while you can quite often even get an implant in there with the typical resorption,
A little bit more. Yeah.
you see during the healing phase, this becomes a problem. And so we want to preempt any of these problems at this stage by grafting and, if necessary, putting tissue in a membrane.
Okay, 15. We always like to utilize vertical incisions behind the canines. We don't like to have them in the area of the aesthetic zone. So if we're going to use vertical incisions, they're used